Hello, my name is Turo Nurmikko and I will be presenting an introduction to the section on pain entitled Pain, Overview and Controversies by Turo Nurmikko, Mark Sindhu and Kim Birchall. In this chapter I will review the history of neurosurgical management of pain, discuss its changing role in modern evidence-based pain medicine, highlight some existing controversies and unresolved questions, and consider to what extent recent pain-related scientific discoveries require neurosurgical expertise in the future. The modern era in the neurosurgical management of pain began at the start of the 19th century. In 1809, Walker proposed that the anterior and posterior spinal roots serve distinct motor and sensory functions. Bell subsequently expanded this idea, and Magendie in 1822 provided evidence of the role of the posterior spinal roots in the transmission of pain. A procedure for the relief of pain was probably first reported in 1873 when Letiewan published his description of peripheral and cranial nerve rhizotomies. Sectioning of the posterior spinal roots for the relief of pain in humans was first proposed by Dana in 1887 and performed by Bennett in 1889. And in fact, the same year also by Abbey in 4 patients. Spiller and Schuller described the pain conduction pathways in the anterolateral columns of the spinal cord in 1905 and 1910, respectively. The first cordotomy as a pain-relieving procedure was performed by Spiller and Martin in 1912 in a patient with spinal cord tuberculoma. By the end of the 19th century, the work of several anatomists and surgeons had led to the appreciation that the anterior and lateral columns of the spinal cord transmit contralateral pain impulses. In 1912, Martin, at the instigation of Spiller, performed the first cordotomy in another patient with a tuberculoma of the cord. The short and long-term results were encouraging and established the technique for treating intractable pain. In 1931, Stuckey was probably the first to perform a high cervical cordotomy for pain in the chest and upper extremity. Mullen and colleagues introduced a technique for percutaneous cordotomy at the C1-C2 level that involved use of a radioactive needle tip and reported it in 1963. The utility of radiofrequency thermocoagulation for creating lesions was applied to the technique by Rosamov and co-workers in 1965. The depth of cord penetration determined by electrical impedance was described by Gildenberg and Associates in 1969. Canpolat and colleagues described a computed tomography-guided percutaneous procedure in 1989. Despite the obvious efficacy of this procedure, particularly for malignant disease and with low rates of morbidity when performed with the most modern techniques, cordotomy remains underused, in part because of advances in pain management, lack of referral, and patient unwillingness to undergo ablative and potentially irreversible procedures. One surgical milestone was reached in 1972 when Sindhu described dorsal root entry zone, or DREZ, ablation for deafferentation pain associated with brachial plexus avulsion and traumatic paraplegia, 2 conditions that previously had been generally considered refractory to all treatment. The procedure was readily adopted by neurosurgeons worldwide and further popularized by Nashold and co-workers who used the radiofrequency thermocoagulation technique. Levy and co-workers advocated use of laser, while Drevel and co-workers used focus ultrasound for the lesioning. Dress lesions for nerve root avulsion pain still remain the first choice of surgical therapy for brachial plexus avulsion pain, a condition in which spinal cord stimulation is uniformly ineffective and response to pharmacotherapy poor. Dress lesions should also be considered in cases of segmental pain after spinal cord or cauda equina injury, in which spinal cord stimulation is of marginal benefit, if any. The rationale behind lesioning of the dress and the dorsal horn is the destruction of the population of neurons that have become hyperactive through mechanisms of deafferentation and gliotic reactions. This has been demonstrated by microelectrode recordings in animal models and patients under surgery. Until pharmacological interventions can be devised to create selective inhibition of deafferentation hyperactivity within the spinal transmission neurons of the spinal cord segment, that's nucleus proprius, dress lesions will remain an important treatment modality for certain types of post-traumatic deafferentation pain. Pain affecting the face, head, and shoulder could not be managed effectively by cordotomy. Spiegel and Weiss used their pioneering stereotactic technique for mesencephalotomy and thalamotomy with greater accuracy and success. Subsequently, Hitchcock introduced a stereotactic technique for pontine spinothalamic and trigeminal tractotomy. Stereotaxy not only enabled more accurate localization of targets, but also generated important insight into the pathophysiologic mechanisms of chronic denervation pain. Lesions in the thalamic somatosensory ventrocaudal nuclei, and these are the nuclei that receive input from neo-spinothalamic system, were not very successful in relieving chronic pain and were often associated with postoperative ataxia and dysesthesia. Attention was focused on lesioning targets of the paleo-reticulospinothalamic system, especially the nonspecific intralaminar nuclei and the pulvinar nuclei with greater success. Development of CT imaging prompted Russell Brown in 1979 to propose a new stereotactic frame, N-localizer, that benefited from the availability of the three-dimensional data. The technique was rapidly adopted by the neurosurgical community and modified to work with magnetic resonance imaging. Further developments followed that led to modern frameless neuronavigation techniques now widely in use. A major milestone in the neurosurgical management of pain came with the publication in 1965 of Melzack and Wall's gate theory. Their proposal that afferent pain transmission might be modulated by a spinal gating mechanism introduced the possibility of pain management by neuromodulation. This motivated Wall and Sweet in 1967 to perform peripheral nerve stimulation, which was at the time the first augmentative procedure for pain relief. Later, the same year, in 1967, Sheely and co-workers performed the first trial of spinal dorsal column stimulation in a patient with pain due to metastatic lung cancer, and succeeded in inducing paresthesia that corresponded to pain localization with subsequent pain relief. This study set off extensive research on the mechanisms of spinal cord stimulation and development of spinal cord stimulation systems with different stimulation outputs, as discussed in chapter 203 of this textbook. In the over 50 years of clinical neuromodulation, several different types of spinal cord stimulation systems have been developed and are today an essential tool in the neurosurgeon's armamentarium, mostly used for chronic pharmacoresistant neuropathy pain and mechanical low back pain. In the late 1950s and early 1960s, brain stimulation, and in particular septal stimulation, was used as an experimental treatment for a number of psychiatric disorders, with some patients reporting relief of their existing pain. Mazar started to test the effect of sensory thalamic stimulation for pain, but reported the results only in 1972. Next year, Osobuchi and colleagues reported their first patients who had received thalamic VPM nuclear stimulation for facial pain. A year later, Adams and colleagues reported their experience with capsular interna stimulation. In 1977, Richardson and Akil implanted a stimulating electrode in the periventricular gray matter in humans and reported effective pain relief. Years later, Tsubakawa and colleagues described the efficacy of motor cortex stimulation for deafferentation pain of thalamic origin. A seminal study by Maravi and others from Lyon used PET to demonstrate increased metabolism during stimulation in the brain's pain modulation networks and changes in the endogenous opioid system. Deep brain stimulation never became a mainstream treatment for chronic pain. In the early 1980s, its increasing use in the United States prompted the FDA to demand evidence of its efficacy. After 2 industry-sponsored trials failed to show a significant benefit of this therapy, FDA rescinded its approval and DBS was designated an experimental procedure for pain relief. This led to a dramatic reduction in its use, and despite some groups in France, Britain, and Japan reporting moderate success in intractable pain, the evidence base remains limited and its clinical use restricted to a few specialized centers in the world. This is in striking contrast with the widespread use of DBS for movement disorders. Similarly, high-quality evidence for the efficacy of epidural motor cortex stimulation is lacking. Hardware development has been slow, and license and reimbursement issues have severely restricted its clinical use everywhere, and in several countries it has fallen out of favor altogether. The discovery of opioid receptors in the central nervous system by Perth and Snyder in 1973, animal experiments of the effect of opioids injected into the intrathecal space by Yaks and others in 1976, and identification of dorsal horn opioid receptors by radioligand techniques in 1977 by Atway and others were the starting points for intrathecal drug delivery systems in use today. In 1979, Behar and co-workers reported successful analgesia following epidural infusion of morphine in patients with cancer pain, and Wang and colleagues reported the same after intrathecal morphine. Subsequently, controlled opioid delivery from implanted pumps was introduced as an analgesic technique for a variety of neuropathy pain syndromes, and with improved technology and introduction of other intraspinal drugs such as ziconotide, baclofen, and bupivacaine became a mainstay neuromodulatory procedure. Controlled trials and large prospective observational studies for pain in advanced cancer demonstrate meaningful pain relief and substantial reduction of systemic opioids with acceptable side effects and reasonable attrition rates, as shown by several reviews. However, for non-malignant pain, the effectiveness of long-term intrathecal opioids is less clear. Prospective studies have shown modest analgesic gains, 45% of patients reporting better than 50% improvement at 2 years, and the complications of therapy, including catheter malfunction, catheter granulomas, and hormonal imbalance, have become more greatly appreciated. Of non-opioids, only one substance, ziconotide, has shown promise in the long-term management of non-malignant central pain, but the experience is still limited. Currently, intrathecal drug delivery systems are indicated in people with severe trunk and limb pain, which has been shown to be refractory to other therapies, and there are detailed international guidelines updated regularly on patient selection, implantation technique, record keeping, complications, and research. On this and the following slide, the chronology of neurosurgical management is summarized in a table for you to peruse in your own time. As you can see, the summary continues all the way to 1991. Next, I will discuss the current status of some of the mainstream neurosurgical pain procedures. Over the years, of all the various neuromodulation treatments, spinal cord stimulation has emerged as an indisputably successful pain-relieving method. A systemic review by Duarte and others in 2020 of 8 randomized sham-controlled crossover studies showed efficacy for spinal cord stimulation in neuropathic pain. Another review by Deer and others found 5 high-quality control trials for low back pain, with or without radiculopathy. There was a minimal overlap between the 2 reviews. The Deer review concluded that for this indication, that is, low back pain with or without radiculopathy, the efficacy of spinal cord stimulation is at level 1. It is worth mentioning, though, that the quality of the included studies left much to be desired. There remain problems in trial design, study conduct, and reporting, which must be addressed in future work. These include the need for investigators to provide unambiguous entry diagnosis, clear process of randomization, suitable controls that receive sham treatment, long-term follow-up, and establishment of blind conditions of patients, investigators, and device programmers. The analysis method need to be pre-specified, including how carryover and period effects are handled in crossover studies, and reporting must extend to treatments and interactions beyond the study interventions. Clinical controversy still exists over the choice of paresthesia-inducing and subthreshold spinal cord stimulation systems, need of a treatment trial before implantation, and choice between tonic and burst stimulations, which will only be solved by well-designed comparative studies. The use of deep brain stimulation for chronic pain remains limited. The lack of controlled studies and relatively small case series of heterogeneous populations have left it short of any substantive evidence base, and that is reflected in withdrawal of regulatory approvals in many countries. And even in those where such approval exists, reimbursement restrictions remain in place. The only studies with adequate sample sizes in the 1980s failed to reach the agreed endpoints. Yet the experience in the 1980s was frequently positive, and some specialized centers keep reporting success from prospective case series, especially regarding intractable pain conditions such as central post-stroke pain. By and large, the situation with motor cortex stimulation is the same. Revival of both types of stimulation could happen, but it will require a better understanding of the neuroplastic changes in general and how they affect responses at stimulation site and across brain networks. Large multicenter studies that focus on careful patient selection, phenotyping, brain imaging, and other measures to quantitate responses and implement methodological rigor similar to that adapted for spinal cord stimulations are needed before the current orphan procedures statuses of these two stimulation methods will change. The many procedures currently used for trigeminal neuralgia, which I discussed in detail in chapters 107 through 200, became established before evidence-based medicine gained its present importance and have weathered well the test of time. Classical efficacy studies, that is, controlled trials of active treatment against sham, are therefore unlikely to add any useful information. However, because nearly all procedural data available is from observational studies, many clinically relevant questions remain unanswered, and there is no general consensus on best treatment strategies. In the next slide, some of these issues are listed. There is also more on this topic in chapter 196. By 2020, there had been no adequately powered prospective head-to-head comparisons between procedures. Therefore, in many common situations, such as the choice of the first ever operation for trigeminal neuralgia in an elderly, or a patient with MS, there are no evidence-based guidelines. The decision is based on neurosurgical opinion, and these vary substantially. And while there is a widespread acceptance that severe compression of the trigeminal root by an artery responds to microvascular decompression, MVD, extremely well, with low long-term recurrence rates, as shown by Sindhu in 2006 and many investigators since, results from a lesser neurovascular compression are less clear. In this situation, both neuroablative procedures and MVD are effective initially, but it remains unclear if the recurrence rates favor one over the other. Improved imaging and neurophysiological techniques to measure the state of the nerve roots and the rest of the trigeminal pathways might be used to phenotype patients, making a randomized head-to-head comparator trial possible, even in a multi-center trial setting. In the next few slides, I will present some thoughts and some predictions regarding the future role of neurosurgery in the management of chronic pain. From the early 2010s, there has been a rapid development of new technologies in brain imaging, electrophysiology, and biochemistry, which has led to a remarkable boost in research. There have been discoveries and developments that have every potential to profoundly change current practices in pain surgery. This will likely be reflected in the way current procedures are being implemented in the future, and this might particularly concern brain stimulation techniques. Therapeutic responses from intracranial procedures are a sum total of local changes and modulation of several networks that are interactive with the site. DBS would be expected to not only activate the descending modulation system, but also interact with network activity in other brain regions, and especially those regions that are responsible for processing of painful signals. These can be estimated using validated imaging and electrophysiological methods suitable for non-invasive testing of both structural and functional connectivity, as well as invasive neurophysiological techniques including microelectrode recordings, local field potentials, and corticoelectrography. Functional connectivity can be measured using resting state fMRI or EEG, and structural connectivity using diffusion tensor imaging and tractography. Some groups have started to use these measures as part of their clinical research. For example, Kim and co-workers conducted a small study of 5 patients with neuropathic pain who were subjected to DBS of VPL and VPM nuclei of thalamus and used probabilistic tractography alongside pain response as an outcome. Patients who benefited from DBS showed maximum connectivity between the stimulation site and primary somatosensory cortex. Elias and co-workers showed in 12 patients with central postural pain that the 5 long-term responders to thalamic DBS had strong functional connectivity between the VII nucleus and posterior insula. And interestingly, responders and non-responders showed different connectivities with the limbic regions. There is intensive research on connectivity-guided therapeutic DBS in movement disorders and neuropsychiatric disorders, and there is no reason why this could not be done for neuromodulation of chronic pain too. An important development worth observing that may shape management of chronic pain in the future is search for reliable biomarkers, whether used as diagnostic, prognostic, or predictive. Pain biomarkers could have a role in complementing subjective pain reporting, identifying a mechanism, facilitating planning for an intervention, estimating the natural cause of the pain, or success of treatment. This work is in progress, in part expedited by the worldwide opioid crisis of the 2010s. The NIH Helping to End Addiction Long-Term Initiative, or HEAL initiative, led to an expert meeting in 2018 that produced a consensus statement outlining the opportunities to discover, develop, and validate new biomarkers for pain. Brain imaging and electrophysiology show substantial potential in this regard. Methods range from EEG and evoked potentials to structural MRI, that is, voxel-based morphometry, diffusion tensor imaging, and cortical thickness analysis, to resting state and task-associated functional MRI, and to MRI spectroscopy and PET. Both diagnostic and predictive biomarkers for chronic pain have been introduced recently. As an example, Baneste and co-workers have shown that thalamocortical activity is present during resting state EEG in a pattern. that distinguishes patients with neuropathic pain from healthy controls. Maravi and colleagues from Lyon used different PET to measure opioid receptor binding potential across several key brain areas in patients scheduled for motor cortex stimulation for neuropathic pain. They showed that preoperative values correlated with the long-term effectiveness of motor cortex stimulation. In a group of trigeminal neuralgia patients, Hung and co-workers from Toronto assessed preoperatively the microstructural pattern of trigeminal pathways using DTI and showed that the results predicted long-term pain relief from subsequent microvascular decompression or gamma knife surgery. For a slightly more futuristic view, let me introduce the idea of restorative neurosurgery. It is well established that following peripheral nerve injury, the dorsal horn of the spinal cord undergoes neuroplastic changes in the local circuitry, and this leads to abnormal nociceptive signaling, hypersensitivity, and pain. There is substantial evidence pointing to reduction of GABAergic inhibitory control at the core of this change. In the first decade of this century, several groups reported symptomatic improvement in neuropathic animals after transplantation of GABA-synthesizing cells into the spinal cord (CSF). In 2016, Basbaum's group studied the effect of embryonic cortical GABAergic progenitor cells transplanted into the spinal cord of neuropathic mice. These cells were harvested from medial ganglionic eminence, or MGE, and are known to be able to synthesize and release GABA. They showed that the transplanted cells integrated and functionally connected with the dorsal horn circuits. Moreover, the cells survived and maintained their GABAergic phenotype and restored local inhibitory control for at least 6 months. The next natural step will be to evaluate the effectiveness of human cell transplantation, implementing advances that have taken place in spinal cord injury research. Stem cell engineering has advanced to a point where neural stem or progenitor cells can be reprogrammed from human fibroblasts or mesenchymal cells into pluripotential stem cells that are considered leading candidates for human spinal cord injury studies. These cells exhibit properties that are similar to those of mouse MGE cells. If, as predicted, transplantation of such cells into the human spinal cord proceeds through the usual clinical trial pathways, it offers the opportunity to use the technique for repair of the dysfunctional dorsal horn of a chronic pain patient. To conclude, I have reviewed the past and present and offered some predictions for the future in relation to neurosurgeons' involvement in pain management. In general, conservative, augmentative, or modulatory techniques are preferred over ablative approaches. Important exceptions include dress lesioning, cordotomy, and neuroablative procedures for trigeminal neuralgia. Development of omics, neurophysiology, and neuroimaging will lead to development of phenotyping and robust biomarkers for diagnostic, predictive, and prognostic purposes. It is imperative to design and conduct clinical trials that fulfill criteria for highest level of evidence. This may include increased use of standardized biomarkers and neuroimaging to assist targeting of the intervention on an individual basis. A final word on training. Training in the fundamentals of pain management must also continue. Few neurosurgeons devote themselves to this, and the lack of expertise has hampered progress in this area. Furthermore, procedures that have proved effective, such as percutaneous gangliolysis for trigeminal neuralgia or DRES lesions for brachial plexus avulsion pain, will fall into disuse if the current generation of neurosurgical residents has no experience with these procedures. Similarly, if clinical research into percutaneous chordotomy or trigeminal tractotomy falters, these potentially useful and minimally invasive procedures will disappear. Training should be comprehensive and range from pain physiology to clinical assessment of the pain patient to wide range of procedures from neuroablative to multiple neurostimulation techniques. Thank you.